Hi, I'm Dr. Jared Gardner, and today we're going to talk all about warts, Verruca vulgaris, and its many different features and patterns, and it's going to be a wart extravaganza. I really like warts, and I realize I've only barely made any videos about warts over the past few years, so it's time to fix that problem, and I've pulled out about 12 or 13 different verrucae, verrucae, that I've come across in practice over time, and some nice examples, okay? So this is a really perfect prototypical example of a verruca. And not every verruca will have every feature that I'm going to show you today. So I'm going to teach you all of the different major features. And then once you recognize it on a perfect example like this, you can begin to recognize verruca that is more subtle and not as classic, okay? So the first thing is that verruca is an infection caused by an infection with the human papillomavirus, HPV. There are many, many different types of HPV. The list of different serotypes or viral different subtypes is growing. It seems like all the time they're adding more strains, and different types of HPV can cause different types of warts on different parts of the body. Genital warts have certain subtypes. Some of the HPV types can cause dysplasia and cancer in the anogenital area or the oral cavity. But the warts that we see on regular skin outside of the anogenital area, and like this one here, which is like I think on the arm or somewhere of a patient, these are caused by a whole bunch of different HPV types. So the HPV causes the epidermis, the keratinocytes, to grow thick and make these finger-like projections, okay? So the first thing about a verruca is you're going to have acanthosis, thickening of the epidermis, right? You can see the epidermis over here is about, I think this is actually the dorsal hand if I recall. You've got about this thick epidermis here, but then in the middle, look, the epidermis is very, very thick. In addition to that, you have these finger-shaped projections on the surface. So that's called papillomatosis. So papillomatosis is a hallmark feature of most verruca. There are some exceptions, but these finger-like projections on the top, thickening of the epidermis. And another feature that you often see, and I really find it very satisfying, is what's called in-toeing, inward pointing of the reedy ridges. So the reedy ridges out here at the side, look at these reedy, they're coming down and they're curving and pointing towards the middle of the wart. On the other side, you see the same thing. They're curving and they're pointing inward towards each other. So at the edges, as the wart grows, for some reason, it causes these reedy to shift and stretch down in towards the middle to point their toes inward towards the middle of the wart. I find that actually to be a very helpful feature. And sometimes if I'm having trouble deciding wart versus seborrheic keratosis, for example, or something else like that, the presence of nice in-toeing will make me say, I'm going to call it a wart, a verruca. Okay, so that's the big features from low power. Oh yeah, and also the corneal layer. There's hyperkeratosis. As these are keratinocyte proliferations, they tend to produce a lot of keratin, which results in a thickening of the stratum corneum, or so hyperkeratosis. And an interesting thing about the hyperkeratosis here, let's go down and take a closer look. The hyperkeratosis tends to be a mixture of orthokeratin, which means keratin without retained nuclei, and parakeratin, which means keratin with retained nuclei. And it tends to have a kind of arrangement, an alternating pattern. And this alternating pattern corresponds to these papillary tips that you see here. So what we get is on the top surface of these papillae, you get this tower of parakeratosis. See the little tiny purple retained keratinocyte nuclei there? They all build up and make this tall tower of parakeratin on the tips of the little fingers. And then in between, you have usually a predominantly orthokeratin. Now, it's not always so perfectly structured and organized this way, but that's why I'm showing you the very best wart first, because it's just as perfect as you could ask. And in fact, sometimes these towers become so tall, they're like spires. People have called them church spires, like on the old beautiful European churches that have the really tall spiky towers on the top. That's what these have been likened to, these church spires of parakeratosis. And then a lot of orthokeratin intervening in between, sometimes with scattered parakeratin kind of mingled in there, okay? So the spikes or spires or towers of parakeratosis alternating with orthokeratin, that's a classic feature of verruca. And then look at these papillary structures, these finger-shaped projections. Go out one power here. They're not purely keratinocyte, right? They're lined by epidermis, basically keratinocytes on the surface, but in the middle they have a fibrovascular core, which is basically just a broad extension of the papillary dermis that's grown up as this papilla has grown up. Of course, it has to have a blood supply because epidermis doesn't have any blood vessels in it, right? The blood vessels always come from the dermis underneath. Okay, so the dermis has to be present here. Otherwise, these tall finger-shaped projections wouldn't have any blood supply and oxygenation, and they'd die. So the dermis here inside the papillae has really prominent dilated blood vessels. That's another useful finding if I'm debating about if something's a wart. I find that in subtle warts, you'll still often find these very prominent dilated blood vessels, thin little walls filled with some red blood cells floating in there, although sometimes the blood cells wash out during processing. See them there? Nice vessels. So those dilated vessels are a pretty helpful feature in the papillary tips. And then look, oh, we're seeing it right in the act. I'll show you something in a minute, but here's where it starts. Blood and fibrin get present in the over top of these tips in the middle of the spires of perikeratin. And the reason that happens is these blood vessels up here are right next to the surface. And so if there's a little break in the epidermis there, blood comes leaking out, and then it congeals up and coagulates and makes a little fibrin aggregate there, okay? And so those get trapped in the papillary dermal tips, and that's a really helpful feature that's often present in Verruca, okay? And here you can see over here, this is exactly what I'm talking about. When we look up there, this one connects down to the bottom, but is just outside of the plane of section that we're looking at here. And you can see a spire of perikeratosis with hemorrhage in the middle of it. So interestingly, this hemorrhage can be seen if you look at a wart with the naked eye. I don't have a picture handy to show, but if you look at warts, sometimes they have little tiny black dots in them. Well, those black dots are actually blood. Remember that even though blood looks red under the microscope, it's because we put hematoxin eosin stain on here, and it's picked up some of the eosin, and it makes it look more red. I mean, it does look red, obviously, when we bleed, but also I think our staining changes how bright that color is. And when there's blood or hemorrhage in the skin or in something, it often looks dark or even black to the naked eye. So these little black dots are actually not black under the microscope. They're just little hemorrhages that are caught in the top. And I remember being told when I was a kid by people that these are called seed warts and that the little black dots are the seeds. Now, I'm not sure how widespread that belief is, but I think that actually the seeds that people call in seed warts are actually just these hemorrhages. But it turns out that actually the warts are contagious because of the virus. So people that said the seed warts will spread because of the seeds, they were right, but for the wrong reason. Not because of this blood is just there. It doesn't mean anything. But in any case, I thought that was interesting. And I speculate that where the idea of seeds came from also is that warts on the bottom of the foot are called plantar warts because of the plantar surface. And I suspect that someone who is a non-medical person maybe heard that at one point and thought of planting in the ground, like you'd put plants in the ground, and made it into plantar, like with an ER instead of an AR, plantar warts, like a person who plants seeds. So that's the story that I've put together in my head. I have no idea if that's actually how this all happened, but I've always found that kind of funny and satisfying. So here's another area where you can see the hemorrhage, and it's turning into fibrin right there, and it's trapped in the perikeratosis because it's come out from the tip here from these underlying dilated blood vessels. So I know I've harped on that a lot, but these little features sometimes are the key to making a diagnosis, because when it looks like this, you just put it down and you're like, Verruca, done. But sometimes cases are subtle and hard, or you only have a partial sample, and that's when knowing all the little features can become quite helpful. Well, I told you these are HPV-driven lesions, but we've not talked about HPV viral effect, or Coilocytes. So if you've studied any amount of pathology, you probably have heard about Coilocytes and HPV. What HPV infects keratinocytes, it has a tendency to make them change and grow larger and make these kind of pale areas in the cytoplasm, and those are called Coilocytes. So this wart does have some very nice Coilocytes, and what Coilocytes look like is they are, like I said, they're going to be enlarged. The nuclei look, to my eye, a little bit grayish. And then the cytoplasm they have is increased, and it's either going to be kind of a pale gray color or have clear vacuoles. Now, the vacuole is kind of an artifact here of processing. See here, these open halos around the nuclei. Part of that is cleared out from our processing, but part of it, you can see the ones that are not totally clear, like down here. Let me go one closer. Try to get it, keep it in focus here. some of it is clearing from artifact of processing, but others actually still, you can see, have some. It may not come up well in the video, but they do have some cytoplasm. It's just a very pale color. So I find that helpful. The if you learned in med school, you know, they talk about Coilocytes seen on PAP. On the PAP test, or formerly known as the PAP smear, which is the cervical exam to screen for cervical cancer, which is caused by a different subtype of HPV than what causes Verruca vulgaris, but HPV all the same. So HPV looks very different to me on a PAP, which is prepared differently than an H&E section of formalin-fixed tissue, which is what we're looking at here. So there is some similarities, like that halo effect that you can have, but I think that they look very characteristic on PAPs, but don't expect Coilocytes to look like that in the skin in a Verruca vulgaris. I'm not sure if it's because of the difference between the HPV subtypes, or if it's because this is HPV growing on dry skin rather than on a mucosal site, or some combination of those. But Coilocytes in PAPs sometimes have that kind of wrinkly raisinoid nuclei people talk about. I feel like you do not see that very well or reliably on skin samples, on skin biopsy with HPV. I feel like the crinkly, wrinkly nuclei is not, to me, a reliable feature, because you often see kind of wrinkling of nuclei as an artifact in normal skin that doesn't have any HPV. But what helps me is that the nuclei are big. They're big and they're pale, and then there's pale cytoplasm. So not just a wrinkly nucleus and not just a halo. I want to see large nuclei, pale, abundant cytoplasm, and ideally, you're going to see granules, okay? So warts often have hypergranulosis. I'll show you some other examples. But not only is the granular layer thickened, but the actual granules themselves, these purple things, are called keratohyalin granules. If you need a refresher on this, I've got a whole hour and some minute video about skin histology that you can go over. I'll put a link down below. But the granules normally are tiny like this, and they're in this top layer of keratinocytes. But here the granules are clumping together. They're coalescing, kind of is one term that's been used, and I like that term, that they're all kind of like pooling together to make mega granules, like massive granules. If you ever watch The Office, I hope I don't get sued by like NBC or something, but Dwight makes mega desk, which is like 3 desks stacked together. So hopefully someone out there is laughing at this reference. And even if this video is watched decades into the future, hopefully future generations will still love The Office and get this reference. And again, hopefully I don't get sued by NBC or whoever it is who makes it. But yeah, one of my favorite TV shows. So I don't think I've ever mentioned that in one of my videos. So you guys are the first to know. All right, so let me go back to lower power here. And again, this is, you already know when you clicked on this, is going to be a long video because I like warts, and we are going to talk about all this stuff. This is wart mega video. So look here. Look at the size of the keratinocytes down here, right, in the basal layer. Normally they're round. They may be slightly bigger in the spinous layer sometimes. And then as you get towards the granular layer up at the top in normal skin, they should start to get small. I guess I should go show you normal skin. Maybe that'd be better. Yeah, here we go. You can see there's the basal keratinocytes. And as we go to the top, the nuclei are actually starting to get smaller as we go up here, okay? Little tiny guys. They sometimes have that little halo. Again, that is an artifact of processing. The tissue shrinks and it pulls away from the nucleus. But contrast these over here with this over here, which are actually coilocytes. Look at how huge those nuclei are. Look how pale and gray they look. Look how not only these cells are just part of the normal granular layer, they're probably actually a little bit revved up because they've been picked and scratched at, because if you had a wart like this, you would probably pick and scratch at it. I've had a wart before, and it is annoying. So not only are the nuclei larger, but the granules here begin to get big and chunky and clumpy and coalesced. So I find that really helpful. I want to see large nuclei, abundant pale cytoplasm, and ideally clumping or coalescing of the granules into much larger mega granules. And that's what I'd like to see for a coilocyte. Now, I've told you everything that I can think of visually about coilocytes, but here's the thing you need to know. You don't have to have coilocytes to diagnose Verruca vulgaris. In fact, I'd say the majority of warts that I see do not have coilocytes or have very few or very subtle coilocytes, not nice big ones. Like, that's why I picked this wart, because it's got a perfect coilocyte. And if you look in my collection, you'll find lots of recuts of warts with coilocytes, because I find them really beautiful to look at microscopically and more visually interesting than warts without them. But in reality, I see many warts on a regular basis that don't have any coilocytes. That's why we're harping on all of the other points, like the intowing and the papillomatosis and the spires of para and the blood in those spires, because those are the features sometimes that you have to use to make the diagnosis. So just remember that if there's coilocytes, great, but they do not require, or you're not required to have them. And oh yeah, I did forget to mention, sometimes you can have binucleation in the coilocytes. All right. So look how big those nuclei are. They're so huge. So that can sometimes be problematic, because the HPV does cause this nuclear enlargement. Occasionally, particularly in sun-damaged patients or on partial samples, the enlargement of keratinocytes from the HPV can cause it can make it challenging to tell apart verruca from, say, squamous cell carcinoma or actinic keratosis or other things that may be handled differently. All right, again, look at how chunky and coalesced those granules are. Very nice example. All right, so I think we've seen all of the possible things to learn from this nice Verruca vulgaris here. And there's the blood in the tips again. Let's see, the hemorrhage. All right, so now let's look at some more at a faster pace, now that we've gotten all of the major features touched on. Here's another example that's very nice and papillomatous, very nice finger-like projection. You can see the intowing again. And look at how thick the granular layer is. Even before you can see if there's chunky coalescing of granules, the granular layer here is much thicker than it is on the adjacent normal skin, right? And again, this is probably like on the dorsal hand or near an acral site, and also has probably been rubbed. So the granular layer is a bit thicker than normal. Also, again, if you haven't seen the skin histology video, you can check it out. But look at this little pink line here. Anyone know what that is? I can't hear your answer, but hopefully some of you are saying stratum lucidum. Well, lucidum makes you think it's pale or clear, but it's actually not. Usually stratum lucidum, to my eye, looks pink, at least on the H&E stains that I've seen. And it's a layer that we were always taught in med school, you know, the basal layer, the basale, spinosum, granulosum, lucidum, corneum. But the only place you actually see, that arrow's kind of bright there, that's better. The only place you actually see the stratum lucidum in the body is acral skin, that is palm or sole skin, or skin that's been rubbed and scratched chronically. That's called lichen simplex chronicus, a reactive thickening of the skin from chronic irritation, okay? So you'll often find lichen simplex chronicus change next to squamous cell carcinomas, verruca, actinic keratosis, anything growing chronically on the skin. People tend to scratch and pick at it, and they get that thickening next to it. But even here, with the granular layer a little thicker than most other places in the body, it's nowhere near as thick as you see here in the wart itself. And this wart also has coilocytes. See how big the nuclei are? Nice, big, fat, juicy nuclei. Much bigger than the basal. Look at the basal keratinocytes here. They're getting bigger in the stratum spinosum here, the spinous layer. And then up here, they get really large. All right? And, you know, look, you also can notice the spines here. The desmosome spines show up beautifully. Look at that. Oh, it's amazing. I never, ever get tired of seeing those desmosomes. It's so incredible. If you are not excited and happy about seeing this, then I cannot help you. I mean, look at that. I look at skin all day long, and I still never get tired of this. All right, so look, the reason you can see there's a little bit of edema, a little bit of spongiosis. That is edema fluid that's seeped up from the dermis into the epidermis and is kind of stretching apart the keratinocytes there. So warts can, just like other skin, can get inflamed. They can get spongiosis. Sometimes the body makes lymphocytes come and attack the wart, and they can get lichenoid change and dying keratinocytes. We don't have that here. But you can have all variation of inflammatory changes in a verruca, okay? So that's totally acceptable and, in fact, relatively common to see. Again, with the intowing, not quite as nice and curved as the last case, but look, here's the reedy out here pointing down straight. As you get closer to the wart, they start curving in, and here they're like going totally sideways, trying to get back to the middle of the wart. I don't know why the reedy want to get to the middle of the wart so bad, but seems like they do. And sometimes in warts, particularly I feel like the ones with nice coilocytes, the parakeratosis, it becomes kind of large. You'll get like large dark dots of parakeratin, like where each nucleus looks much more round. And again, I think that's because these are the coilocytes that have died and become part of the the stratum corneum, the corneal layer. And so because their nuclei were larger when they were alive, their nuclei are larger now, as opposed to the kind of thin little wispy, kind of spindled looking nuclei that you see in the flattened normal parakeratosis. But anyway, that does happen sometimes where you get this large parakeratosis, and occasionally, like I've seen times where HPV-driven squamous cell carcinomas, like in the vulva, have this large kind of atypical looking parakeratosis, but I've also seen that plenty of times in regular old Verruca vulgaris. So in a site like the anogenital area, I might be cautious if I saw that and couldn't see the whole lesion underneath, but otherwise it doesn't bother me if I see what otherwise looks like a perfect wart. And again with the hemorrhage and the spires of parakeratosis. Okay. And look, that in-toeing is so dramatic. Like all the toes are like kind of fusing together almost to become like one. They're all like so curved in. And this one is not nearly as acanthotic as the last couple I showed you, okay? There is acanthosis though. See, here's the normal epidermis here. And then look how much thicker, if you go from the granular layer down to the basal layer, the epidermis here is much thicker. Another interesting thing is, look, this wart is like kind of cup-shaped. It's what we call endophytic. But it's also a little exophytic too. It's got papillae still, but the bottom of the wart is actually sitting down below the skin surface. So that happens sometimes with warts, particularly warts on acral skin, palm or sole skin, fingers or toes. You can get this very endophytic push-down wart where it's got the features of a verruca. It's got the papillary projections, the papillomatosis here, but they're sitting down in like kind of a bowl or a cup that's pushed down into the dermis. And also look how thick the corneal layer is. Sometimes the corneal layer can get really, really thick, particularly on warts on acral skin. And so there'll be times where a good dermatologist has done a nice thick shave and they thought that they've gotten me enough to get the wart. And all I'll see is the corneal layer with some spires of parakeratosis. It'll look basically like, imagine this was the whole biopsy. I'll be like, well, this is probably the top of a wart, but I can only really see like one little finger-shaped projection of keratinocytes. So what would I do in a case like this? Well, for one thing, it depends on if I've got a shave like this and it's from, the foot of a 12-year-old kid, well, guess what? That's going to be a wart, right? Almost certainly. Now, if it's on the forearm of an 80-year-old sun-damaged guy, then I got to be a little more cautious because there are times that you can have very wart-like features on the top surface of an invasive squamous cell carcinoma. So in cases like this, I'll say, well, this is suggestive of a superficially sampled verruca, but there's very little actual viable epidermis here, living cells that I can actually look at. So it may not be representative. And again, I tend to add those hedging comments more on patients who are more likely to have a squame, someone who's older and sun damage, rather than, a young kid. I just say, this is probably the top of a wart. And I might add just that I'm only seeing the stratum corneum mostly. And so that if it continues to grow, they could go and resample it, which they may need to do anyway, because, ideally, a lot of times people want to get rid of the wart, and warts can be quite challenging to treat. I actually had a small palmar verruca that I acquired like last summer. It was a tiny little thing, and it was really painful. If I put my hand down on the desk by the microscope, it was painful, and I actually had some of my derm colleagues, I got it frozen a couple times, and in the end, they had to do a pulsed dye laser to finally get rid of it, which was somewhat painful, but it actually did get rid of the wart, and I was very thankful. So now you know my story about my palmar verruca. So it's a too much information episode of my YouTube channel today. All right. So anyway, there you go. Wart that's got, look at that in-toeing. You couldn't ask for better than that. It's like you could hang it on your wall or something. It's just amazing, right? The in-toeing is so fascinating and cool, and it's like so perfectly curved and uniform here. All right. Now this one, and again, you're like, all of these have coilocytes pretty much. So again, I pick out the ones that look best, and sometimes the ones that look best to me are ones with coilocytes. So, again, in real life, you're not going to see coilocytes as often. From low power, obviously a wart, all the stuff I told you, papillomatosis, spires of parakeratosis, intowing. The reason I picked this one is you can see the huge granules even from here. I'm on 2x magnification, okay? You can still see the granules. So the granules here are massive, huge granules. And again, the cells around them, they're actually in the granules are most prominent in the coilocyte cells. That you can see the large gray nuclei here in the granular layer and the big coalesced granules. So I just wanted to show this one as an example of really dramatic hypergranulosis and massive coalescing of granules. See, there's the normal size of the granules, these tiny little powdery little specks, and then here we've got these massive, huge things. So I'm not sure why the HPV makes this happen, but it's kind of cool looking, I think. Now, a new topic to discuss here on this one. Now this looks good for a wart. It's got all the stuff we talked about. It's got a massive thick layer of keratin on the top, so much that this is what we would probably call clinically a cutaneous horn. And I have a whole video about cutaneous horn and the different things that can make it. It can be made by squamous cell carcinomas, actinic keratoses, verruca, sometimes even seborrheic keratosis and other things. And so the only way to know what's underneath a horn, and if you want, I've got a video, like I said, I'll put a link down below, and it's got some pretty dramatic clinical pictures. These look pretty wild sometimes clinically. But the only way to know is to biopsy and see what's underneath, what's growing all that keratin. So here what's growing in is a wart, and we can see the whole lesion here. They got a nice biopsy right under it. We can see all of the epidermis. You can see the nice rounded intowing of the reedy at both edges. The papillomatosis here, not as dramatic as the other cases, right? So this again is why we go over the features. The intowing is very helpful, and that's what really I think is the best feature in this case. There are a few papillae, but they're kind of blunted and small. But there is hemorrhage up there in the surface, and that hemorrhage is in those little spires of parakeratosis. And when we look away from the spires, what we have is mostly orthokeratin with just a little sprinkling of parakeratin nuclei in the midst of it, okay? So it's mostly kind of thick ortho with just a bit of parakeratin blended in. And look, even though the papillary shape, the finger-like projections, is very kind of, this is like a sad excuse for a papilla here, but look, it's got those dilated vessels. So see, the dilated vessels can be really handy sometimes when you don't have nice obvious papillary projections. There's a little bit of coalescing granules here, but much more subtle than the cases I just showed you previously. And coilocytes, I mean, maybe those are a couple coilocytes, but they're certainly nothing to write home and to your friends about, okay? So and then here's kind of some hypergranulosis at the edge. Now, the reason I want to bring this one up is look at how large and glassy the keratinocytes are. I'm trying to get the light right. And what we mean by glassy is there is abundant, dense pink, keratin-filled cytoplasm. When keratinocytes get a bunch of extra pale pink cytoplasm, and kind of it looks smudgy or dense, we sometimes say that those are glassy keratinocytes. Now, the reason that glassy kind of matters is there are some types of squamous cell carcinomas that get very glassy keratinocytes, and there are also other things like keratoid xanthoma, which I usually regard as a form of squamous cell carcinoma, although other people have strong opinions otherwise. But I've got a whole video you can go check out about that if you want to know. But in any case, there are other things that can get glassy. Hypertrophic actinic keratoses tend to get abundant glassy cytoplasm. So the glassiness here, and sometimes the nuclei begin to get enlarged, okay? Whether this is because of the HPV virus change, or because the wart is being irritated, or there's inflammation, or a mixture of those, I don't know. But I often see larger keratinocyte nuclei and abundant pink glassy cytoplasm in verruca. So the reason that's important is that can mimic squamous cell carcinoma, particularly if you have a partial biopsy and it's on, say the forearm of an old sun-damaged person, the kind of person who's likely to get squamous cell carcinoma. So this can become problematic if you don't see the whole lesion. So again, look at the size of these nuclei here in the wart. Let's go out to the edge. Look at how much smaller. I mean, these are much smaller out here at the edge, much bigger in here, okay? So the atypia, there's really not any dramatic atypia here. I should have probably pulled out one that was much more difficult. But I do think that you do have kind of revved up enlarged nuclei along the basal layer here. compared to normal. Yeah, look at that. Small, little round nuclei down at the bottom. Much bigger nuclei here. And like I said, that's a feature I see in warts, but I do recommend using some caution when you can't see the whole lesion. So the reason, like I said, is that sometimes squamous cell carcinomas can have areas that look very much like a verruca on the surface. And I've seen that many times. And I have a whole video about squamous cell carcinoma and actinic keratosis. And I think I've got some examples in that video. And I also just released a short video recently. I'll try to remember to put links to these down below that shows a real nice example of a wart on the surface that looks like a wart and then actual full-blown squamous cell carcinoma underneath. So say I had a biopsy just like this. Well, this is one where I might say, you know, this could represent a wart, but there's some glassy atypia and it's broadly cut across or transected at the base of the shaved biopsy. And so I'm not sure it's representative. I can't exclude something more aggressive underneath, like a squamous cell carcinoma. So I add some comment to that regard, and I'm going to release some comments about how I handle complex situations. And when I get around to doing that, I'll put some examples of how I word my comments in my report, and you can check that out. Again, I'll put links down below so that you can go and see how I end up wording these things in real life. All right, but I might say this very well could be the top of a wart, but I just can't see the bottom, and especially in a sun-damaged older person and a broadly transected lesion where I don't see what it's doing at the base of the lesion, at the deepest part of the lesion, that's where I want to be cautious. All right. And I add some comment about that, you know, if nothing else, they need to follow the patient. And if it grows back or continues to grow, then they need to do a deeper biopsy or completely conservatively excise the whole lesion. But here, because we got a nice deep shave, this is helpful. And if you're a dermatologist watching this, by the way, I want to point out that I know it's hard, especially when you got a horn, and especially if it's on the extremity, like the leg is the worst because it's an older person, their leg, you don't want to do a deep biopsy because they may bleed, they may not heal very well if they have a poor blood flow, and stasis changes. So I understand the hesitancy to do a deeper biopsy, but I will say, especially when it's an older sun-damaged person and there's a concern for squamous cell carcinoma clinically, if you can get a deep enough shave to ideally try to get underneath the whole epidermis, underneath the lesion, that's going to make it much easier for me to be able to give a definitive answer that this is verruca without hedging and saying I'm not sure, and I can't exclude this and that. So I totally not blaming you. I recognize the struggle's real, and I totally understand not wanting to do a deeper thing. But on keratotic lesions, a deeper shave that lets me see the whole base of the lesion is often, to me at least, I don't know about other dermpaths, but for myself at least, makes it much easier for me to give a definitive answer without hedging. And a transected one, a lot of times I have to hedge because I just can't see what's happening underneath. So that's if you're able to do that, it's going to help me to give you a better answer. So here again, I don't think any hedging was needed. I think in this case I just called verruca, and I think I said it was inflamed. Here you can see there's a little bit of inflammation and some blood there. And a good example, though, of the kind of glassy atypia that you can see in some verruca vulgaris. All right, a few more to go, and then we'll be done. If you're still with me, you are a trooper, and you're going to be the master of all verruca from this day forth. Now, here's an example of one of those transected ones. And look, this dermatologist did a great shave. It's a huge, thick piece of tissue, but this wart was a really thick, deep wart. So sometimes it's just not possible. And that's, I think, particularly a problem on warts with horns and also warts on acral surface. I think this was on the thumb or somewhere, if I recall. So we're just seeing the top of it. Now, this was a young patient, and so I didn't need to hedge or say, oh, well, it could be a squam. I just said verruca, superficially sampled. But a good example of what the top part of a wart looks like. See, we're just seeing those top papillae. I'm not seeing the base, but in this patient who's young, and also, if I recall, this particular case had Coilocytes too. So bonus. And I feel like one of my former partner when I worked at my former job, Dr. Sarah Shalin, who's a brilliant dermpath and was a wonderful person to work with for the first 8 years of my practice, and she taught me so much dermpath. She's just brilliantly smart. She told me that that she notices Coilocytes much more often in kids and young patients, and I feel like that turns out to be oftentimes right. Not that you can't see them in adults, but they do seem to be more abundant in warts from younger patients. So one of the many great diagnostic pearls that Sarah Shalin has taught me over the years. Now look at this. Here's the skin surface way down here. and we've got this massive tree of a wart blossoming out or growing out and sprouting out of the skin, pushing way up. So really a kind of a polypoid sort of wart. And sometimes these can have really thin little elongated papillae that stick way up from the surface. Particularly you see those like on the upper cheek or near the eyelids. And when they have a lot of little thin elongated kind of thread-like papillae, you can call them a filiform wart if you want to get kind of fancy, or you can just call it Verruca. I'll say Verruca, filiform type, just for fun, but it honestly doesn't matter at all clinically. It's still Verruca, that's all that matters. But this particular example is a good example of how pedunculated and polypoid warts can sometimes be. And the hypergranulosis is evident from low power there. And we've got para alternating with ortho. And this one, again, had some coilocytes. I guess I should have thrown in more that lacked coilocytes here to make it more true to life. But there they are. Look at how gray that cytoplasm is. See how that, I really like this one because you can see normally keratinocytes have pink cytoplasm, but here there's gray, pale cytoplasm kind of pushing the pink keratin-filled cytoplasm out of the way. So that's a really nice, helpful feature, I think. And some types of warts, I have other videos about this, a type of flat wart that is called EDV, epidermodysplasia verruciformis, which is actually a genetic syndrome, but normal people that don't have that syndrome can also get warts that look the same. And they have not only a gray, but like a really blue-gray cytoplasm, and they look more like a flat wart. But you can look up EDV on my channel if you want to see some videos about that. Those are very beautiful to look at microscopically. And there's some more of that large, like really big nuclei in the parakeratosis here. Dilated vessels. See, they're almost always, like every wart I've shown today, I think has dilated vessels. It's a very useful feature. And there's another one that's kind of pushed up above the skin surface. Also really massive hypergranulosis, very, very thick granule layer there. And this is on the face, you can tell because of all the large hair follicles and sebaceous glands in the background. And it was probably a person who probably thought it was going to be a squamous cell carcinoma, so they took it out with a little ellipse here to make sure they got it around it, I imagine. I don't remember the history from this. It was a long time ago, this one, I think. Right now, it's kind of a strange pop. Wait a second. Can you figure out what's happening here? Because this often confuses people a lot. This is upside down. So what we're looking at is this. But because of the shape of these, when you get a specimen like this, it often is confusing if you've not seen it before. Here's the skin surface way up here, and this is on the bottom of the foot, a plantar wart. And plantar warts are often endophytic, like this, pushed way down. I don't know exactly why it is, but I like to imagine it's like from walking on it all day long, it continues to press the wart deeper and deeper down into the dermis, but the wart keeps trying to grow back up. So you have this cup way down, and then these finger-like projections, again, sitting in the middle of the cup or the bowl. Okay, so yeah, if you do a shave biopsy on this, I mean, a normal shave, there's no way you won't even get even the tips of the papillae. You'll just get the top of normal skin and then stratum corneum. That's it. Okay? So you really have to kind of like get deep down under this with the blade and pull it out like a plug. I don't exactly know how my awesome derm colleagues get a great specimen like this where they pop the whole thing out, but they just kind of got right under it. This is a perfectly removed example. Really nice because they got all the way under the lesion and just kind of popped it out. But I feel like you see this pattern right here most often on acral surfaces, particularly the foot. And again, it can be very confusing because when it's flipped over, it looks like it's a kind of strange, bulging polypoid thing until you notice that this stuff up here, that's not stratum corneum, it's dermis. An easy way to tell it's dermis is, look, it's got blood vessels in it. Stratum corneum doesn't have blood vessels. Dermis does. So that I think someone tweeted one of these a while back and did a poll and asked if the lesion was the right way up or not, and I think the majority of people got it wrong. So that's not to shame anyone who got it wrong. The point is that this is a thing that people struggle with, because until you've seen this and had it explained, you'll be like, what is going on? Especially if you don't happen to get that little bit of epidermis there. So if you just had a cut through here, you could really kind of have a hard time orienting yourself. So, and then all the features here are the same. Look at the intowing. Amazing intowing there. How about dilated vessels? Yeah, although it's a little interesting. They got some dilated vessels, but also there's a lot of like sclerotic collagen in the background in this one. I don't know why. And the para and all the stuff that we've talked about. All right, and the last three are just to show you that warts don't always have to be this big and dramatic. Sometimes they're just tiny little things. Here's another one of those little ones from the eye that's probably like kind of a filiform wart, little tiny thread-like papillae coming out here, and they often just get snipped off with a little scissors. And so you may only just see a few papillae there, and the hypergranulosis, and then there's some blood and spires of perikeratin up there. It's a little tiny verruca there. Here's an even tinier one. Look, this is like a little tiny baby wart. It's just a couple papillae, no coilocytes, but there is hypergranulosis. See, nice thick granular layer. Can't really tell. There's maybe a little intowing, but it's kind of hard to tell here because we have such a small shave. Little spire of perikeratin. Just a little wee wisp of it right there. And you might have trouble seeing how this is a wart if all you've seen is the really dramatic ones, but I honestly probably see warts like this. I mean really often. I mean, many of the warts I see are warts that do not make it into my study set over time because I only tend to save the really great dramatic ones and get recuts. So this one, the papillae are much more blunted and rounded, okay? See how they're kind of a little bit rounded? Now, one thing, whenever I see rounded papillae, I do think about genital warts, condylomas. So if this is like on the forehead or something, well, probably not a condyloma. I mean, I guess anything's possible. But in any case, if I see something kind of with features of a wart but rounded, kind of knuckle-shaped protrusions instead of finger-shaped protrusions, and it's in an anogenital site, then much more likely we're dealing with a condyloma. And I'll do another full video about condyloma at some point in time because there's some different things you have to consider and handle in that situation. But I've also noticed though that warts in fold sites, like particularly like the axilla, maybe sometimes around the neckline, that warts in those fold sites can also get this kind of rounded, knuckled shape like you would see in an anogenital condyloma. So here though, if you also go over here, then it kind of sticks up a little more, looks a little more wart-like. You can kind of imagine vaguely that there's some like intowing, like the edges of the lesion point in, but it's nothing like the intowing I showed earlier. There's no coilocytes, but there is acanthosis. There's this kind of vague, subtle papillomatosis. Just a couple little kind of rounded papillomatous stuff coming up. There's a spire of para right there. There's a little bit of para there, but it's mixed with ortho. So again, that mixture of alternating ortho and para. Dilated blood vessels. Now, other things can have dilated blood vessels too, okay? But I do find that actually a helpful feature for verruca. There they are again. See, there's really nice big dilated blood vessels here going up into that kind of polypoid area. Hypergranulosis, but not very chunky and coalesced, a little bit, and no good coilocytes in here at all. So I still think this is a verruca, but it's much more subtle, and so I hope that this 45-minute mega episode of all the things you want to know about warts has been helpful to you, and hopefully you can see the progression from the really classic, perfect examples to some of the oddities, all the way down to these lowly little tiny ones like this, which are actually the bread and butter things that we encounter all the time. And if you don't know what the classic ones look like and all those, the perfect dramatic features, sometimes it's harder to recognize the more subtle ones. So anyway, if you've watched this whole thing, cheers to you. You're awesome. And again, hopefully you found it helpful. Thanks so much for watching. Have a great day.